Hi, everyone. Thank you so much for joining us today. As parents and caregivers of children with neuroblastoma, we know how complex and overwhelming this journey can be. We are constantly searching for answers, for clarity, and for options that might give our children the best possible chances, not only to survive, but to live fully and with quality of life during treatments and beyond. The main goal of this series of webinars is to give you the most up-to-date information out there to navigate this almost impossible journey. We all know the statistics and we all understand how critical it is to develop new treatments and drive research forward, because our children deserve the best possible chances. That's why today's session is so meaningful. Today is the 8th session in our monthly series, and we are honored to welcome Dr. Giselle Sholler, one of the leading experts in neuroblastoma research worldwide. Dr. Sholler is the chair of Beat Childhood Cancer Consortium, a collaborative network of over 50 hospitals and research centers working together to develop clinical trials and bring new treatments to children with cancer. Dr. Sholler is also practicing pediatric oncologists and researcher, who have dedicated her career to finding better therapies for children with high-risk neuroblastoma and relapsed. One of the areas of research that her team and collaborators have been focused on, as many of you know, is DFMO, an FDA-approved drug currently being studied in neuroblastoma as maintenance therapy to reduce high risk of relapse and to reduce risk of relapse and after frontline treatment. Today's session is a chance to learn more about this research, but also about other clinical trials and treatment strategies being developed through Beat Childhood Cancer. Most importantly, it's a space to ask questions and to gain knowledge. We truly believe that knowledge is one of the most powerful tools we have as parents in our children's care. Some of you already submitted questions, and we've shared those with Dr. Sholler. It's truly an honor to welcome you, Dr. Giselle Sholler, and we thank you for sharing your time and expertise with us, and we look forward to your presentation.
Thank you so much, Nat, for inviting me here today to talk with everyone and share a little bit about our work. I'm going to just share my screen now, so I can share my presentation. And into slideshow mode. There we go. Can everyone see my screen okay? Perfect. So thank you so much. I'm going to talk today about the Beat Childhood Cancer strategy from DFMO to other trials that we're working on right now. As a conflict of interest, I have conflicts with US WellMeds, YMABS, Recordati, and Nature's Toolbox. So the Beat Childhood Cancer Research Consortium is a group of hospitals that have come together. We have over 55 hospitals through the US and Canada, as you can see on this map, that will work together to try and find solutions for neuroblastoma. We are hoping to expand this year beyond the US and Canada into Spain and Brazil and Israel to share our clinical trials worldwide. I'm thankful to be able to work with so many physicians and researchers that are really focused on neuroblastoma and trying to find solutions for better outcomes. As we know, for this group knows, neuroblastoma is the most common non-brain tumor, solid tumor in children that occurs generally between 2 and 6 years of age, with 2 peaks of incidence, those less than 18 months and those at 3 to 5 years of age, with very varying outcomes. And so the biology is very different for the low and intermediate risk. So you can see we have a much better prognosis versus the kind of 3 to 5-year-old group that is the high risk neuroblastoma, which with incredibly poor outcomes. And that's really the group of patients that we focused our work on. For high risk neuroblastoma therapy, generally takes about 18 months standard of care from induction, which involves chemotherapy and surgical resection of the primary tumor, usually anywhere from 5 to 7 cycles of the chemotherapy. The end of induction, the goal is to be in as close to a remission as possible, and then to move on to consolidation therapy, which generally involves autologous stem cell transplant and then radiation of the primary tumor and other remaining areas of bony disease. After consolidation, our standard of care here now is anti-GD2 antibody with cis-retinoic acid. And the addition of anti-GD2 antibody to retinoic acid as part of the immunotherapy portion really was the first large increase in event-free survival. And we saw that from this study, the event-free survival increased from 4 years of 44% to 54% with the addition, so an increase of 10% with the addition of antibody therapy. And so then from this trial, that became our standard of care. But what you can see is during the gray section here is the time where patients are receiving antibody. There's still a decrease, about 14% of kids still relapse during antibody treatment. But what's still important is that at the end of immunotherapy, for those next 2 years, there's still a large drop in event-free survival. We're still seeing quite a bit of children relapse. And so prevention of relapse is still needed. While we can get many children of high risk neuroblastoma into remission and through all of that care, about 30% of relapse occur still within the first 2 years. And most patients who relapse often will die within 5 years. And so one of the drugs that we've studied is DFMO to focus on relapse prevention. And that is because DFMO targets polyamines. So I just want to stop for a minute. What are polyamines? They are small, positively charged molecules that are present in most cells and are really essential for cell proliferation, survival, and differentiation. They have a role in cancer growth. They stabilize the DNA, enhance transcription and protein synthesis. Polyamines contribute to the immunosuppression in the tumor microenvironment, but most specifically, they are very important in cancer stem cells. Polyamines regulate the expression of stem genes like Lin28, MYC, and SOX2. And these are important in the relapse. Those cancer stem cells are what can then cause relapse. If we look at a tumor, only about 1% to 2% of the tumor itself is a cancer stem cell, highlighted here in red. Most chemotherapy affects rapidly dividing cells. So your chemotherapy is killing the cells that are rapidly dividing, while the stem cell stays quiescent. And then since it's been left behind within that first 2 years after treatment, it can cause a relapse. If we can use medications that target the cancer stem cells, then that can result in tumor shrinkage and tumor regression. So again, one of those pathways that's important in the cancer stem cells is the Lin28 LET7 pathway, which DFMO, through inhibition of ODC, that's the gene that it blocks, decreases polyamines and then decreases Lin28, which then reverse increases LET7, which is a good thing because then that suppresses MYC-N. So DFMO has been shown to be an irreversible inhibitor of ornithine decarboxylase. It reverses Lin28 and also decreases glycolytic metabolism. So can we use DFMO to target these cancer stem cells? In some of our preclinical work, we looked at 2 different neuroblastoma cell lines here. And increasing doses of DFMO for 48 or 72 hours, we saw that Lin28 decreased, MYC-N decreases, and then other cancer stem cell markers all decreased. And so what does that mean? Well, if there's a cancer stem cell present, this red cell again here, and we put 1 cell per well in 96 well plates, only the cells that have cancer cells that are cancer stem cells can reform a tumor. The others cannot reform the tumor. And that's called a neurosphere assay. So we look and see in the lines that are red, they have no DFMO. And as we increase the concentration of DFMO in 5 different neuroblastoma cell lines, what we see is that there's a decrease in neurosphere formation. In vitro, what we're able to see is we're able to inhibit tumor formation, inhibit the cancer stem cell from forming the tumor when DFMO is present. So in summary of our in vitro work, DFMO inhibits ornithine decarboxylase, decreases polyamines. What I haven't shown, it also increases G1 cell cycle arrest, induces senescence, restores the Lin28 LET7 balance, and suppresses neurosphere formation, all resulting in a cytostatic response in neuroblastoma. So it's preventing the cells from being able to reform the tumors. So with this work, we moved forward with a phase 1 trial of DFMO. So in a phase 1 trial, while we're really wanting to use DFMO to inhibit tumor formation, With the FDA, the first study of a drug in a patient population needs to be a phase 1 trial, and these are trials of patients who are with neuroblastoma disease present who have relapsed and have been told they're incurable. What we were able to do was test 4 different doses of DFMO to evaluate what is the best dose to move forward into a phase 2 trial. In this study, because patients did have active neuroblastoma, we treated them with the DFMO alone for 21 days to evaluate the side effects, and then in combination with low-dose oral etoposide as well for an additional 5 cycles. What we found that all doses of the DFMO that studied from 500 to 1500 milligrams per meter squared were safe. There were no dose-limiting toxicities. What was interesting was that 3 children who were told that they were incurable, all given less than 6 months to live, were all found to be curable with the combination of DFMO and low-dose oral etoposide. All of these children were on study for over 2 years and now have been 10 years since completing the study and remain in remission without any additional therapy. So their tumor had continued to shrink even after stopping DFMO, suggesting that the cancer stem cell was inhibited and the cancer was able to regress on its own. During that time, we also moved forward with in vivo work in animal models to mimic what we hope to do in a clinical trial. Animals were given low levels of neuroblastoma, either 10 cells injected into this flank of the mouse, 50 cells or 100 for this neuroblastoma cell line, or 500, 1,000, and 5,000 for this neuroblastoma cell line. The mice were then put into different groups. Some mice were given regular drinking water, and then the other mice on this side were given DFMO in the drinking water. And what we were able to show was that with minimal neuroblastoma present in the mouse, those that had regular drinking water formed tumors, while those that had DFMO in the drinking water were unable to form tumors, preventing quote unquote relapse in these mice. And we can see that the survival was improved as well in those mice. And so that moved us forward to our phase 2 study of DFMO with high-risk neuroblastoma. Again, these patients received chemotherapy, surgery, transplant, radiation, and antibody and cisretinoic acid. At the completion of immunotherapy with cisretinoic acid, patients were enrolled on study and given DFMO for 2 years to see if we can prevent that sharp decrease in survival for the first 2 years. Just a reminder here, this was the immunotherapy curve, and that patients at the end of immunotherapy followed this black line. So from this point out to 2 years, about 30% historically would have relapsed. And so this is our historical control. What we saw in our patients that at 2 years, 85% of patients were still in remission. So about 50% less relapses than expected. We expected 30% relapse, only 15% relapsed. And what was interesting was that once we reached the 2-year time point, the curve really stopped dropping. Even at 4 years, we're still at 83%. Many questions we get asked is, was there a difference between MYC amplified or non-MYC amplified patients? Well, historically, MYC amplified patients often do worse. We were able to show here that both MYC amplified and non-amplified had similar event-free survival rates of 85 and 86%. And then when we compared to overall survival compared to our historical control estimate, we saw that 97% at 2 years and 95% of children were still alive 4 years from the start of the study. Our historical estimate was about 75 to 80%, so significant improvement in overall survival. Again, this was a historical estimate. And so when we talked with the FDA at that time, they asked us to see, could we find a fit for purpose external control? What we noticed that many of our patients had come directly from the ANBL0032 antibody study. So we were able to obtain that database from the Children's Oncology group and compare our patients that had been on this study and went on to DFMO compared to ANBL0032 patients who completed standard of care and would have been eligible to get onto DFMO, but did not receive DFMO based on the center they were at. We compared these 2 patient populations, and they were very similar. And when we looked at the complete group are 92 patients who received DFMO versus the 852 patients that were on that study and could have qualified to receive DFMO. We saw a very significant difference, similar to what we had estimated. At 4 years, we had, instead of 72% of patients in remission, 84% of patients were in remission. And the overall survival was even more significant as we moved further along. 84% of patients were alive who did not receive DFMO, while 96% of patients were alive that did receive DFMO. It was really this major difference in overall survival, children alive versus not, that led the FDA to work even more closely with us. When we look at side effects of DFMO, we see that about 10% of patients do have a decrease in hearing. Often this hearing loss is reversible. Again, it's this important of this hearing loss is that it's in all speech ranges, not just in the high frequency that you often see with chemotherapy. Given that it is in the speech range, we really want to make sure that if it decreases more than 20 decibels, we hold the medication, allow it to reverse, and do a dose reduction. These are some of the other things that were noted for children 2 years on DFMO, but again, most of them are less than 5 to 10%. 70% of our children on their phase 2 study had no adverse events. So then the FDA asked us to do propensity score matching with the database that we had. So propensity score matching matches each one of our patients to 3 patients in the database based on all risk categories to find a patient that looks just like one of ours in the database. It reduces bias when you're comparing patient data from different sources. It matches individual patients to optimize the similarity of the 2 groups. It balances the covariates and then reduces confounding differences. So you better isolate the treatment effect. These were the 11 categories that we decided to match our patients. And you can see for each, making it amplified or non-amplified was an exact match. The others were matched based on the score of the other 10. And we can see, so each of one of our patients, we found 3 patients to match. When we do that, the patient characteristics become almost identical between the 2 groups. And then when we look at even other variables, before the green was pre-matching, and then with the matching, everything is in the blue within the 0.1 standardized difference. So the patients are very identical. And in doing that, we were able to show, again, the similar improvement in event-free survival from 73% to 84%, and improvement in overall survival that really just continues to increase even beyond. The 4 years was 84 versus 96, but even at 8 years, the difference is much, much, much greater. And so hundreds of additional sensitivity analyses were done. Again, if it's on the left side, it all favors treatment with DFMO as improving outcome. And that resulted in FDA approval of iwilfin on December 13 in 2023. This is really named after 2 of our children. Will was one of the 3 little children from our phase 1 study who was cured with the DFMO after many relapses with neuroblastoma. And Finn is the nephew of one of the vice presidents from US WorldMeds who really led that company to being interested in DFMO and interested in neuroblastoma. Finn's also has completed his 2 years and has done really well with DFMO. And so now medication is called iwilfin in the United States, and it's approved for high-risk neuroblastoma patients after immunotherapy. So DFMO is cytostatic and targets the cancer stem cells. Inhibition inhibits tumor formation both in vitro and in our in vivo model. And then we were able to show that in children with DFMO, it was able to prevent relapse and increase survival. We do have many other additional clinical trials looking at DFMO ongoing. One of our studies is the DFMO 006B. It's an expanded access for patients with Lin28 and MECAN expressing tumors. So on this study, patients do need to come to Penn State to enroll, but can have access for patients with neuroblastoma that may not fit onto one of the other clinical trials, or patients such as ETMR, DIPG, Ewing's, osteo, medulloblastoma, other tumors that have Lin28 or MECAN important in those tumors. Our 014 study is looking at 2 different doses. One of the questions really has been, is this the right dose? So we're looking at 1,000 milligrams per meter squared twice a day versus 2,500 milligrams per meter squared twice a day. Does increasing the dose potentially increase the event-free survival rate? And so that study is continues ongoing here in the US. We do have a randomized study, which I'll mention as well, 012. I'm going to go into more detail on that, but during immunotherapy, as I mentioned earlier, 14% of patients still relapse. What if we added the DFMO during immunotherapy? Could that decrease the relapse rate there? And then we have another study for relapse refractory neuroblastoma, the 015 study, that combines DFMO with oral etoposide like our phase 1 trial. We do have a medulloblastoma study for maintenance for children with high risk and ultra high risk medulloblastoma to see if we can prevent relapse in those patients as well. And our 020 is a combination of DFMO and AMXT, which I'm going to talk about. So the first study I just wanted to mention was our randomized clinical trial. Again, this is, while we had worked with the FDA, one of the questions was, is there a place in therapy where randomization might be possible? And so we do have a clinical trial ongoing at the beginning of immunotherapy. Patients who have received chemotherapy and at least radiation plus or minus transplant could enroll. They're randomized equally based on all risk categories to receive either dinutuximab and retinoic acid or cetuximab, retinoic acid, and DFMO. Again, DFMO also increases the immune environment in tumors, and so that may make the antibody more effective. And so the overall survival, primary objective is progression-free survival. At the end, while it is randomized during the immunotherapy time, at the end of immunotherapy, all patients receive DFMO for 2 years at that time point. It's about 225 patients per arm, and so this is going to be, we have enrolled about 80 patients so far, but a study that is going to take time to complete. And our next study that I just wanted to mention is the 015 study of DFMO with etoposide. Currently, arm 3, which was subjects who have relapsed refractory with active disease, is closed. We've enrolled all of those patients. And we are still enrolling on patients who were either refractory to upfront treatment, but eventually were able to get into remission with additional therapies, or any patients who had previously relapsed and now shows no active disease. So in CR2 or greater can enroll on this study and receive DFMO with oral etoposide. One of the biggest questions is, can we further enhance the targeting of polyamines? So neuroblastoma cells can get polyamines internally. They can make their own polyamines using the gene ODC, and DFMO inhibits the internal making of the polyamines. But cells can also get polyamines from the bloodstream. These are taken up by a polyamine transporter into the cells. And so this can be blocked by a drug called AMXT-1501. It's a polyamine transport inhibitor that lowers polyamines within cells. And so if we combine DFMO and AMXT-1501, the cells cannot access polyamines. We were able to show in different neuroblastoma cell lines that these are, we showed that they were synergistic, these are synergy assays. If it's below the line of additivity, then it's synergy. And we also were able to show that it inhibits cell growth. The purple line is the combination of the two, decreased the cell growth significantly in 3 different cell lines. And we're able to show that the combination also decreases polyamines within the cells. And so the primary objective of this study is to evaluate, there's a phase 1 and phase 2 portion of the study. In the phase 1 portion, we're going to be looking at safety, tolerability, and determining the recommended phase 2 doses of AMXT in combination with oral DFMO. And once we determine the recommended phase 2 dose, we'll then be able to move on. During that, we'll also have secondary objectives looking at progression-free survival and overall response rate. In the phase 2 portion, we're going to evaluate the neuroblastoma cohort will be a randomized clinical trial, while the others will be single arm. We are going to have 4 cohorts in the phase 2, the relapsed refractory neuroblastoma, which will be randomized. I'll show you that schema in a moment. We're also going to open this trial up to children with relapsed refractory ETMRT and ATRT, patients with DIPG at diagnosis, but after standard of care radiation therapy, and then sarcomas, including Ewing sarcoma and osteosarcoma. So there'll be many different groups that can access this. The primary objective is progression-free survival. The secondary objectives will be overall response rate and overall survival. This will be the neuroblastoma arm because patients will be randomized equally to arm A to have DFMO and AMXT, or arm B with just DFMO, because we do know that DFMO alone can be helpful. There'll be evaluations every 2 to 3 months. If a patient on the DFMO arm does have a progression, they can cross over and receive the AMXT and DFMO because the primary endpoint will have been met of a progression-free survival. And then the next study, those are our current DFMO clinical trials. So I wanted to share with you some of our newer trials. We have a combination of phase 2 study of naxitamab added to induction therapy for subjects with newly diagnosed high-risk neuroblastoma. So this is really based on a lot of other previous work. As you know, GD2 is a sphingolipid that is highly expressed on neuroblastoma cells, and many anti-GD2 antibodies have now been developed. As we showed earlier, the COG AMBL 032 study showed that adding immunotherapy after consolidation improved event-free and overall survival. Cyapan in Europe has also shown with dinutuximab beta that it can increase event-free and overall survival as well in post-consolidation. Dinutuximab has also been combined with irinotecan and Temodar and shown to be effective for relapsed refractory patients. And then naxitamab, which is another anti-GD2 antibody developed at Memorial Sloan Kettering, showed an overall response rate of about 50% in patients who were relapsed refractory with residual bone and bone marrow disease. And when we look at St. Jude's study with their anti-GD2 antibody, they showed that in addition of the anti-GD2 immunotherapy to induction chemotherapy improved end of induction response rate. So the St. Jude antibody showed that they had 66.7% had a greater than or equal to a partial response after just 2 cycles versus 31% on the COG study. In addition, end of induction response of VGPR plus CR resulted in a 67.7% CR VGPR rate relative to other studies that have shown only 42 to 48%. So significantly improving, but adding immunotherapy to chemotherapy, we're able to improve end of induction response rates. And this is important because when we look at the COG end of induction, CR had significantly superior event-free and overall survival than those that had less than a CR. So we can see in the red line, those that have a CR, that are in complete response before starting consolidation, do better than those that don't in terms of long-term event-free and overall survival. In addition, Dr. Strebe and et al. Looked at Curie scores and showed that patients who had a Curie score of 0 prior to going on to transplant had significantly better event-free survival as well. And so our goal is to really improve our end of induction response as a surrogate for long-term overall and overall survival. So the antibody that we've chosen to move forward with in our clinical trial is naxitamab. As I mentioned earlier, it's been safety and efficacy have been evaluated in 2 open label single-arm trials with high-risk neuroblastoma for relapsed refractory disease and bone or bone marrow. And those are the 2 areas when we're trying to get patients into a CR at the end of induction. Since we do have surgery for the primary tumor, it's often the bone and bone marrow components that we're really looking to improve response rates, which naxitamab really targets. And so we're adding naxitamab to all 5 cycles, starting patients receive a biopsy and they get naxitamab, cyclotopo for the first 2 cycles, stem cell transplant, stem cell collection, and then cycles 3 through 5 with surgical resection happening after either cycle 4 or cycle 5. So this is our overall schema when we put the two clinical trials that I just talked about together. Our 018 study is trying to we're adding antibody to upfront chemotherapy to improve um, end of induction response rates to have patients in as close to a remission as possible prior to entering consolidation. Patients can receive consolidation per standard of care at their institutions, and so this is not prescribed by the Beach Health of Cancer. And then patients can enroll on our NMTRC 012 study where they receive either dinutuximab with cis-RA or dinutuximab cis-RA and DFMO for the 6 cycles, and then everyone receives DFMO at the end to try again to bring more children into remission in induction and prevent as many relapses as possible. We did have an amendment to our study for our chemo-nexapalimab. Our goal is to have a Curie score of 0 to move on to consolidation. And so if patients do not have a Curie score of 0 at the end of induction, they have a positive bone marrow or a Curie score greater than 0 due to bony disease, they then will also on study can receive bridge HITS therapy. So the nexapalimab with irinotecan Temodar for up to 4 cycles before moving on to consolidation. And so, as I mentioned earlier, this is all patients have whole exome, whole transcriptome sequencing and diagnosis. They receive nexapalimab with the chemotherapy, and they have an end of induction response. They do have responses measured after cycles 2, 4, and end of cycle 5. If at end of cycle 5, they're poor responders, if they're not a Curie score of 0, they will then go on to receive irinotecan Temodar and have disease evaluations after every 2 cycles until they receive that Curie score of 0 before moving on to consolidation therapy. Again, the primary outcome is to evaluate CR-VGPR rates based on the 1993 criteria at end of induction for newly diagnosed high-risk neuroblastoma patients treated with nexapalimab and standard induction therapy. The secondary objectives are to evaluate response rates using the 2017 overall response rate of CR and PR for children with high-risk neuroblastoma, and then also to evaluate the CR rate at end of induction based on the 2017 INRC criteria. In addition, we're very interested in making immunotherapy more effective. So we do have a new clinical trial that just opened this fall, a phase 2 study of nexapalimab in combination with a new drug called tipifarnib for patients with relapsed refractory neuroblastoma. So what is tipifarnib? It's a potent selective oral inhibitor of farnesyltransferase, which is an enzyme that's important for transferring farnesyl groups to proteins, including oncogenic proteins like RAS. It inhibits angiogenesis, induces apoptosis, and has anti-proliferative effects in tumor cells. The first farnesyltransferase inhibitor to be tested in clinical trials was tipifarnib, and it's generally well tolerated in pediatric patients. Most side effects are related to either blood counts or GI toxicity, such as diarrhea. And so, why do we want to combine tipifarnib with anti-GD2 immunotherapy? Well, one thing that's important with neuroblastoma cells is they can secrete extracellular vesicles that have found to be crucial regulators of tumor growth, progression, metastasis, and development of drug resistance. The tumor extracellular vesicles also carry biologically active molecules with the capacity to influence the tumor microenvironment, especially the immune system around the tumor. Neuroblastoma-derived extracellular vesicles actually decrease the maturation of NK cells induced by anti-GD2 antibodies within the spleen, and they decrease the anti-GD2 monoclonal antibody NK cell infiltration into the tumor microenvironment. Instead, they increase the tumor-associated macrophages, which suppress the immune system, which we don't want. So our hypothesis was that treating tipifarnib with nexapalimab would, one, counteract the immune suppressive effects of the extracellular vesicles, because tipifarnib will block the extracellular vesicles coming from the neuroblastoma cells. And that would then restore the immune cells in the tumor microenvironment. So restores the NK cells and T cells around the tumor to increase the anti-tumor effects of nexapalimab, and then increase overall response rates in patients. And when we looked at the preclinical work of combining naxitamab and tipifarnib, we were able to show that this combination suppressed neuroblastoma tumor growth and prolonged, specifically, overall survival in the mice. And so our objectives in the study is first is a run-in safety. So the first 6 patients need to be over 6 years of age to enroll in the study. And we'll be looking at safety and tolerability of giving patients with relapsed refractory neuroblastoma who have disease present, tipifarnib, and then in combination with naxitamab. The first 6 patients will be evaluating for dose-limiting toxicity and safety, and then we can move into children who have a lower age range. The primary objective is to evaluate the activity of tipifarnib in combination with naxitamab for relapsed refractory neuroblastoma based on overall response rate. And then the secondary is to evaluate the duration of response, defined as the time from the first documented response, CR or PR, to the date of the first documented progression. And then to evaluate the efficacy of tipifarnib in combination with naxitamab based on event-free and overall survivals and the safety again. And then we'll also be doing a subcohort of patients who have only bone and bone marrow disease, because that is the indication for which naxitamab was approved, with a response rate of 40 to 50% in the bone and bone marrow disease group alone. We do think it's important to test in patients with solid tumor, not just bone and bone marrow, because of the effect on the tumor microenvironment may show a response there. We do have some exploratory objectives. On this study, we're going to be looking at biomarkers associated with this and also looking at circulating exosomes, or those secreted vesicles that come from the neuroblastoma, and as well circulating tumor DNA analysis and patient's plasma as a biomarker of disease burden and treatment response. We'll also be generating cell lines from patients who are actively on the study as well, and doing genomic analysis of the patient's tumors to evaluate the targeted pathways to further correlate with response. So again, this is the schema for the study. It's an open label phase 2 study. Patients will have tipifarnib and naxitamab given together. Every 2 cycles, we'll have an evaluation with MIBG and bone marrow. The inclusion criteria are any patients aged less than 21 at diagnosis or greater than 12 months age at enrollment. The exception is the first 6 patients must be greater than 6 years for the safety run-in. And the disease subjects must have relapsed or refractory neuroblastoma with active disease, measurable with at least 1 centimeter by CT or MRI, positive MIBG or PET, or positive bone marrow. And subjects with any CNS disease currently taking steroids must be on a stable dose of steroids at least 1 week prior to their biopsy, and must not have progressive hydrocephalus at enrollment. So those are the clinical trials. I also wanted just to mention, because we do get a lot of calls from patients about our information project. So the Beach Childhood Cancer has a precision medicine program, and this is not necessarily a clinical trial, although there is a biology component that is a clinical trial. But our information project, we're doing whole exome, whole transcriptome sequencing of our patients. Patients can come and enroll on this. The whole exome, whole transcriptome sequencing is done at diagnosis, at any relapse. For patients who have multiple relapses, we are doing clonal evolution to evaluate what is changing in the patient's tumor over time, and what pathways might we want to target. Then we have our bioinformaticians do an analysis of both the DNA and the RNA. Again, we do 25,000 genes in the DNA and 25,000 genes in the RNA. That's put into a program called Ingenuity Pathway Analysis. And you can see the pathways for the patient's tumors are drawn. We look to see what medications might target that patient's cancer. We host molecular tumor boards every week nationally from Penn State that look at each patient's tumor in depth to look at what medications might be helpful for that patient, and put together treatment plans with up to 4 different medications given together. For patients who enrolled prior to their biopsy being taken, we also were able to create cell lines and xenograft models of our patients' tumors to then study the medications that we predicted might be helpful to see which their cell line responds to most effectively. And then again, we collaborate with researchers, and we share the cell lines, tumor tissue, et cetera, with others on other research labs doing research in neuroblastoma, so that we can increase the amount of research happening in neuroblastoma across the world. So that's another project that we're working on that is open to anybody who's interested in having their tumor sequenced and looked at more in depth. And so I just want to thank everyone from the Beat Childhood Cancer, most importantly, the patients and families who participate in the research and really inspire us to work harder every day. And many of our foundations, especially the Beat Childhood Cancer Foundation and Four Diamonds Foundation, who funded the majority of this work. Thank you. I will stop there. And I know that was a lot of information, but happy to talk and take questions now. Okay, I can get to the chat. There were. Oh, there's Q&A, I see. So one of the first questions here was from Maria Hupka from Germany. Can you tell me anything possible hearing loss with DFMO? How severe is it? How is it treated? How many children experience hearing loss? At the standard dose, the incidence of hearing loss is about 10% of patients. At the higher dose, we do use a higher dose for patients with CNS disease, such as either neuroblastoma that spread to the brain or medulloblastoma or ETMR. And then at 2,500 higher dose, we see about 25% of patients have hearing loss. So it is dose dependent. For patients that are on the standard dose, again, it's about 10% of patients. It occurs in all speech ranges. And so it is something that's important to, what we do is we hold the medication, and usually about after 1 month, we'll recheck the hearing test. It's a reversible hearing loss, so we'd like to see that increasing back up to normal. It may not go all the way back up to normal, but it should increase. Then we are able to start at a lower dose. We do about a 25% dose reduction, and we can do 2 25% dose reductions as needed to ensure that patients can complete the 2 years without having that hearing loss affected. The next question that I have here, is there a trial that would be appropriate for a patient that has twice relapsed, now NAD for 10 months, but still on naxitamab only once the naxitamab is ended? So that's the 015 study would be the study that patient would qualify for. Now that's our study with DFMO with low-dose oral etoposide as a maintenance therapy for patients who relapsed twice and now are in remission again. What have you seen work best to target the soft tissue for refractory patients? Does DFMO work to cure soft tissue, i.e. lungs? We have not used DFMO for soft tissue disease. We have seen it with the DFMO in combination with oral etoposide has decreased soft tissue disease in some of our patients in the chest as well as in the paraspinal. So that is a possibility, but not with rapidly progressing disease. For soft tissue disease, we often use dinutuximab or enticantamidar or dinutuximab cyclotopo in patients with first relapse for soft tissue disease. One of the things we do will be the precision medicine program, where we do the sequencing to really try and understand what pathways are most important in that child's cancer. In addition to that, another combination that we do use for soft tissue disease is oxaliplatin and doxorubicin. That's been published from the UCLA. That's been another good combination to decrease soft tissue disease. Next question is, what have you seen work best to target soft? Oh, no, look at that one. Sorry. How useful is VMA and HbA urine in detecting early relapse? We have found that in 80% of patients, the urine VMA and HbA is a very good marker of detecting early relapse. We do monitor that for all of our patients at the beginning of every cycle of chemotherapy. It's very easy, low-cost test to do that can help us identify if the tumor markers start to increase. It's important to get a scan done to look for early relapse. So we do. So next question, in DFMO study 3B, one of the inclusion criteria is DFMO must begin 1 to 120 days of completing prior, cytotoxic and antibody-based therapy. However, in clinical practice, we sometimes encounter patients who remain in remission but exceed 120-day window. What would be your recommendation to managing such patients? Do you think there's room for flexibility in this timing criteria when considering DFMO as remission maintenance therapy? Yes, on the first study, we wanted patients within 120 days to start so that they would come directly from the previous study and enter and start DFMO before giving the chance for relapse. If patients are beyond 120 days and they're still in remission, we do allow them to start DFMO if possible, up to 6 months. So what we have been finding is patients from other countries sometimes are having a challenge in getting visas to be able to get to CS to get to onto the DFMO. And so as long as it's within the first 6 months, we've still allowed patients to enroll and receive DFMO for maintenance therapy. We do think it's important to start as soon as possible, but we've extended it out to 6 months here to try and allow patients to have that time to get here, because sometimes it takes a little bit longer. But as soon as we recommend, as soon as they're done their upfront treatment, starting on DFMO, our goal is within the first month is the ideal. Oh, Tom, hi. I have a question about DFMO if it's been repurposed for other cancers, such as adult cancers. There was a lot of study in adult colon cancer as a preventative agent in combination with DFMO and Solandac. But in terms of other pediatric cancers, we are using it in medulloblastoma to prevent relapse, in Ewing's and osteosarcoma, based on Dr. Loeb's work from Montefiore. His preclinical studies have shown that in animal models, he's able to prevent relapse in osteosarcoma, Ewing sarcoma models. And that study will be opening likely by September through Beats Childhood Cancer as well. And then the DIPG work done in Australia by Dr. Ziegler and their team there showed that DIPG responded well to DFMO in combination with AMXT. And so that study we're moving forward as well. As I mentioned, the O20 study. So it is definitely being looked at in multiple other cancers that have cancer stem cells as an issue in terms of relapse, the Lin28, Lit7 pathway. Do we have to come to Penn State for the genomic sequencing trial? So we do have to. So for patients that want to enroll on the genomic sequencing study, we do need to see the patients to enroll on the biology portion of the study. And then for us to send the genomic testing. The genomic testing is covered by the Beat Childhood Cancer Foundation. And so that portion of the testing can be done here. But we do need to see the patients to be able to give clinical recommendations for that study. Is there any correlation to how long a child stays in remission to overall survival? Definitely the higher how long prior to relapse is what in general, in pediatric cancers overall, it has been shown that earlier relapse tend to be more aggressive disease and have a worse overall survival, versus the later relapse tends to increase overall survival. But I don't have that data exactly for neuroblastoma, but it kind of across the board in pediatric cancers. Yes. Any results, feedback from the DFMO AMXT study? We have not opened the DFMO AMXT trial. We're aiming to open this by the 1st of September. So we're still working with the FDA on some safety issues. And then we hope to have that study open by September to start enrolling patients as well. My son relapsed in January 2025. I'm sorry. He took DFMO for 1 year prior to relapse. He's now clear again. We're debating between DFMO again or vaccine. Would getting a higher dose of DFMO be an option for him if he relapsed on DFMO once? Can DFMO be effective if we give it a second try? We have done that with patients who have relapsed and gotten back into remission. We do treat with the higher dose DFMO, the 2,500 milligram per meter squared on the 006B trial. And we do have children that have done well with that. I think the question of which trial, we don't know which one would be better, the DFMO higher dose or the vaccine. So it's an important one to talk with the team at Sloan Kettering, if that's where the vaccine is going to be done, to look at outcomes that they've seen. We can share with our patients our data with the higher dose DFMO. We have quite a few children that have done well. We've seen children, especially if they've relapsed in the CNS, and then had resection, and when we've treated patients with a higher dose DFMO to then treat the CNS as well. And many of our patients have done well, which we're putting that data together. Would DFMO dosage in line with PSA be increased again after an adverse event, say liver not hearing? Liver toxicity, yes, we likely would, depending on how high. We've in my experience, I've not had to decrease dose based on liver toxicity, so I would love to hear more about that one. Really, at our hospital, the only reason I've had to decrease dose has been due to hearing. Once we decrease the dose due to a hearing toxicity, we do not increase the dose again. So that definitely for hearing, we don't increase the dose again. But for the liver toxicity, I'd have to understand more about that. If a child has hearing loss from cisplatin, does DFMO increase their chance to lose more hearing? That does not seem to correlate. Most of the kids, 70% of kids coming onto DFMO have toxicity due to cisplatin, and it doesn't seem to be correlated with DFMO hearing loss at all. Many patients who have high dose cisplatin hearing loss, it just stays stable throughout. So again, I would say about 70% of our patients already have some hearing loss enrolling on DFMO from cisplatin, but only 10% have hearing loss, additional hearing loss because of DFMO. So hello, not a DFMO question, but do you know if there are any trials on high-dose chemo-immunotherapy? If yes, high-dose chemo-immunotherapy. Any evidence statistical effectiveness? What are your thoughts on it? So we're doing the naxitamab with immunotherapy, which is upfront immunotherapy, which is relatively high dose. So the chemo-immunotherapy upfront. What we're seeing is it's relatively well tolerated, adding the naxitamab. The Children's Oncology group is also doing a randomized study, adding dinutuximab to upfront chemotherapy. Our group selected to do the naxitamab because naxitamab is really only given over 1 hour on day 1, half hour on day 3, 2, 3, and 5. So much easier to give in combination with chemotherapy post the antibody versus a 12-hour infusion of immunotherapy while giving chemotherapy is a little bit more challenging. And in addition, we chose the naxitamab up front as well because patients will get dinutuximab posts. And so if there's any resistance that builds to the dinutuximab while they're getting it up front, that would make it less effective later. And so we wanted to have 2 different antibodies to give the children the benefit of both, which is why we chose the naxitamab with induction chemotherapy. It's preliminary, and so we can't share our results today, but it's been very, very well tolerated. And next question was, in advance, I missed your explanation. Why do you recommend 2 years time frame for DFMO and not longer? Thanks. 2 years was the time frame where it's the biggest drop in event-free survival before it starts to flatten out. What we in our first study was, okay, let's treat for 2 years. Is that long enough? And do we potentially need to treat for longer? So we stopped at the 2 years to see. What we saw was that after 2 years, there are very, very, very few relapses. And so we don't feel like it was beneficial or to continue to extend the DFMO beyond the 2-year time point. When the relapses happen on DFMO, it's usually within the first year. And then after 2 years, we've seen very, very few relapses. Although it is possible, we didn't feel like continuing the DFMO would increase the survival rate significantly. And then the next question says, I've seen A and below 1221 study references up to 17 cycles of dinutuximab or anti-antimatter for local relapse. It seems like a lot. If patients receive a CR after 4 to 6 cycles, would you continue or monitor and switch to DFMO oral etoposide? So generally, our group would probably stop after 6 cycles, 6 to 9 cycles at the most of antibody or anti-antimatter once patients have received a CR. and then switch to a DFMO, oral etoposide, or other combination for maintenance therapy after that. And then Vicki said, thank you so much. A wealth of information to digest. My questions relates to, do we know yet which patients are more likely to respond to DFMO? Any key biomarkers that may predict response? You mentioned ctDNA. We are measuring circulating tumor DNA in patients' blood on our current studies. It's a research question, so it's being tested at the end. But we don't have, and we have looked at genomic sequencing of patients upfront. And our bioinformaticians are working on studies to try and correlate which patients would best respond to DFMO versus which would not, or which might need higher doses to respond. But we don't have those results yet. I think that's a really important question because while we're able to decrease the relapse rate by 50%, 50% are not relapsing, are still relapsing. I mean, and so we do need to do better for those patients. Perhaps the DFMO AMXT may be the next solution for that, but we have not found the biomarker yet to identify which patients will benefit. So that's a really important one to continue studying. I think that's the I think the. Oh, wait a second. So one more question. It was, two more questions. Why is chemo part of a maintenance therapy? And what are the additional side effects of that? So we, this was work that we had done a long time ago, looking at which chemotherapies might be best to combine with DFMO. And when we combine DFMO with low-dose oral etoposide, the low-dose etoposide in the lab, we showed that the two drugs together were synergistic. And so we wanted to find a medication that could be given as a maintenance therapy with minimal toxicity. And so low-dose oral etoposide given at just 50 milligrams per meter squared per day for 14 days on, 14 days off. With the DFMO, we were able to have kids without dropping their counts, without losing their hair, without too much nausea, able to have a long-term, good quality of life outside. And so that was really the reason. But the first was the lab work, showing the synergy between those two medications, and then selecting this as an agent that can be given long-term with minimal toxicities and side effect. And then, in your opinion, what is the survival rate now for high-risk neuroblastoma? Also, relapsed neuroblastoma, what is your opinion with all the new developments and new survival rate? So the survival rate now for high-risk neuroblastoma has significantly improved. It's hard when we do piecemeal studies of induction, consolidation, maintenance, and extended maintenance. So for patients who make it through immunotherapy and receive DFMO, the overall survival rate now is in the 90th percentiles and significantly better. But we do know that some children still relapse during induction chemotherapy or progress. I think adding the naxitamab or the antibodies during induction will help minimize those children that relapse or progress during induction. And then again, moving on to the immunotherapy and DFMO, I think our overall survival rate will be, upwards of 80%. I think we're doing much, much better. But we need to keep doing the trials, keep improving the treatments until we get to not only better overall survival, but better tolerated therapies that have less toxicity for our children so that they can survive and thrive and beyond their high-risk neuroblastoma. And I know for the new relapsed neuroblastoma survival rates, historically we used to tell children that they're not curable once they've relapsed, but that's not true anymore. We've seen through many different trials, ours and others, that children with relapsed neuroblastoma can be salvaged, can get back into remission, and can remain there. And that's the goal for all of our kids. And it's 2:00, so I will stop right on time. And I think I got to majority of the questions.
Yes. Thank you so much, Dr. Sholler, for first of all, for giving all of us so much hope, and for your dedication and for everything you're doing. Your success is our success, of course. Our next speaker next month, August 5th, will be Dr. Lisa Dealer. It's all about survivorship, long side effects, and what to expect and more. See you next month, and thank you everyone for joining us.